Hey class, it's Dr. Dorf. Want to do a quick lecture about thyroid disorders, thyroid disease rather. I'm someone who has thyroid disease. I have hypothyroidism. Talk more about that in a minute. First, let's kind of talk a little bit about risk factors and associated conditions in which you'll find underlying thyroid disease. So one, Down syndrome, very common for hypothyroidism. Elderly patients, you can see hypo or hyper, usually atypical presentations in elderly, but you need to be thinking thyroid disease when you have elderly patients, which I know is very hard when you get the 80-year-old that comes in and says, hey, I'm tired. But anyway, it needs to be a consideration. Use of certain medications that can cause an alteration in thyroid function. The most obvious one, of course, would be iodine. Other one, antiarrhythmics that we'll see, amiodarone for rate control with atrial fibrillation. Some medications used in the treatment of schizophrenia and bipolar disorder, most commonly lithium. So those are some of the most common medications that you'll see. Thyroid disease tends to be more prominent in the female gender rather than the male. And that's for both hyper and hypothyroidism. Main reason is because most thyroid dysfunction is autoimmune in nature, and those diseases are more common in women than in men. We'll talk about autoimmune later in the program, but that's the reason why. Also, you can see it commonly in postpartum. Of course, that's going to affect women more so than men, obviously. Usually that's a transient hypothyroidism or a transient thyroiditis. Other things you need to talk about, personal or family history of, again, any autoimmune disease. We already talked about the ties to that. Pernicious anemia, type 1 diabetes. And of course, any history of head and neck surgery that required irradiation to take place. So that's kind of what you need to be looking at on the lookout for in terms of risk factors and associated conditions. So let's talk about identifying thyroid disease. Most commonly, that is done through labs. And right now, the most currently available and highly sensitive and specific test is the measurement of TSH, also known as thyrotropin. It's the most helpful thyroid test, particularly in diagnosing the condition in the outpatient setting. And you'll see that's our lead-off hitter right here. Also, you'll see that I'm sparing you guys my lovely handwriting and have decided to give you some pre-typed tables here to make it a little bit easier for you to read. So I'm giving you a little break from my chicken scratch tonight. So anyway, TSH, it's produced and released by the anterior lobe of the pituitary. That's somewhat important to know. So once again, TSH produced and released by the anterior lobe of the pituitary. And the main reason is that it's part of a negative feedback loop. And that's all kind of done through the anterior pituitary. So, and that feedback loop is kind of in response to the amount of circulating thyroid hormone, otherwise known as T4. And we have a couple of different T4 level measurements here, free T4 and total T4. So a small fraction of T4 circulates in the free form, with about 99.7% of that being bound to T4 binding globulin or other plasma proteins. The unbound portion of T4, or what we call free T4 right here, is metabolically active. Again, unbound and metabolically active. That's the key thing to look at with free T4. Measurement of free T4 is also the most helpful test to confirm an abnormal TSH level. So you get a TSH that may be done as a routine annual wellness examination, and that comes back abnormal. Next thing you want to add on to that is a free T4. Again, mainly due to the fact that it's unbound, metabolically active, and that's going to be your follow-up test for confirmation. Okay? So keep that in mind. Then you have about 40% or so of your T4 is then converted into T3. T3 is basically metabolically active, just like T4 is. It's unbound. It's 4 times more metabolically active. It talks about this. It talks about how about 20% of it is circulating in the form of thyroid. You have also, I forgot to skip over your total T4, also sometimes referred to as serum T4. You'll see that test, unfortunately, commonly drawn by providers, and it's very much an unnecessary test. It's very much out of favor with the AACE. And you can see here in big bold letters, rarely an indicated test. In fact, we'll scribble underneath here, useless test, don't order, as a reminder. So really, it's not going to give you a whole lot in terms of assessing thyroid function. And that's the key with all these labs, by the way, before you get too caught up into all of this stuff, is the goal here is how does this best assess thyroid function and tell me what's truly going on with the thyroid and the function. Total T4 is not going to tell you a whole lot. Really neither is free T3 or total T3. Sometimes you'll want to get a free T3. There are certain settings where that's okay, but total T3, total T4, or again, serum, you can alternate the total for serum. Just don't order. Again, it's not going to give you a whole lot of information in terms of what you're trying to accomplish. Here we go. Thyroid peroxidase antibodies, TPOs. So this is a test to help detect autoimmune thyroid disease. Talked about earlier, one of the things you need to look out for in terms of risk factors is any underlying autoimmune disease. Is technically thyroid is considered an autoimmune disorder. It's endocrine disorder, but it's also an autoimmune disorder. And the reason is this is what helps kind of identify if we have autoimmune thyroid disease. And basically it's measuring an antibody against peroxidase, which is an enzyme that's held within the thyroid. So that's basically what we're doing in terms of labs and in terms of what we're looking for, what we're measuring. So once again, TSH. If abnormal, whether high or low, you're getting a free T4. That's going to be your next step. T3 can be done in some cases, but gold standard, first step, second line, never do the totals. And then your antibodies if you're suspecting autoimmune thyroid disease. We'll talk more about presentation of that forthcoming. So that's quick down and dirty on your thyroid labs. So let's talk about the different thyroid disorders that you're most commonly familiar with, have heard, or have come across so far in your readings and in clinical practice. So that's going to be hypothyroidism. We'll start off with that. So these are going to be your patients that are going to be coming in. They're going to be complaining of fatigue. That's primarily due to reduced energy release, slow cell turnover by the thyroid. And it mentions up here that these hormones, your T4 and T3, they act as cellular energy release catalysts, and they influence. They're a big powerhouse for the body. As you'll see, they find out they regulate several things. But that's why people often come and complain of the dragon butt, as I like to call it, or they're fatigued. You need to be considering hypothyroidism. Causes, a lot of this for hypothyroidism is going to be due to post-autoimmune thyroiditis. In fact, about 95% prevalence in North America. That's primary pituitary failure. It's due to dietary iodine deficiency, most common reason for hypothyroidism worldwide, by the way. Not that common in North America because we eat a lot of salted foods, but just FYI, now you know. These patients are also going to have lethargy. Talks about here mentation, that they can't make sense, thoughts too slow, so they may be lethargic, they may seem disinterested, maybe having some memory issues as well, so you need to assess for mentation. Reflexes, it talks about that things kind of get hung up, and that there's and we're primarily talking about the patellar reflex. So if you're assessing for deep tendon reflexes, again, going back to assessment class, thinking about how to assess for DTRs in the patella, this is going to be, instead of a quick out and quick back action when you stimulate that patellar DTR, it's going to kind of get hung up, and they're going to be overall kind of hypo-reflexic. So keep that in mind. So weight is going to be an issue in the setting of hypothyroidism. You're typically going to see weight gain. It's not huge. If you look here, it talks about just about 5 to 10 pounds. Okay, so it's not someone comes in and they say, hey, I've gained 20 pounds in the last week unintentionally. Thyroid may be a consideration, but you need to look at something potentially scarier than just thyroid issues. So let's talk about GI issues. These patients are usually going to be talking about constipation from a GI standpoint with hypothyroid. Females, again, it affects females more than males. They're going to have menorrhagia, which is heavy menses, in case you don't know what the medical term for that. They're going to have, in terms of intolerance to hot or cold, these are the people who are going to be talking about that they're easily chilled. They're just cold all the time, all right? They're going to have thick, dry nails. That's kind of not in here, but they're going to be thick, they're going to be dry. Hair is going to be coarse hair, tendency to break very easily. They're going to have coarse, dry skin. Also, you may see, from a cardiovascular standpoint, some bradycardia. That's typically in very severe cases of hypothyroidism. So now we get into some other different issues with hypothyroid, Hashimoto's thyroiditis. So this is going to be autoimmune in origin. It's one of the most common forms of hypothyroidism in the USA. Is Hashimoto's. It's inflammatory disease of the thyroid. And again, it's often linked with other autoimmune disorders. So you need to kind of work that up. If you have a patient who has Hashimoto's thyroiditis, you need to be looking for underlying autoimmune disorder. It could be anything from RA to Sjogren's to lupus. So be looking for that. Most commonly seen in women 30 to 50 years old. Clinical presentation, usually going to be a diffusely enlarged thyroid. You may be able to palpate some fine nodules, may complain some neck pain, some tightness. They're going to be rocking a nice goiter. The goiter may regress over time, but once you start getting treatment on board. But anyway, that's kind of the picture of your Hashimoto's patient. Again, you want to be checking those antibodies that we talked about, those TPO antibodies, and that's going to be kind of letting you know that hey, yeah, this patient has Hashimoto's. Also, you need to, we talked about the different medications already that can cause hypothyroidism, and of course, anyone that's had any post-radioactive iodine treatment, head and neck surgery that's caused, that they've had radiation or iodine treatments. All right, let's talk about hyperthyroidism. So conversely, with hyperthyroid, some characteristics of that. These are going to be people who are going to have excessive energy release because you're having very rapid cell turnover. In terms of skin, this talks about they're going to have a very smooth, silky skin. They're going to have very fine hair with frequent loss. In terms of their nails, they're going to have thin nails that break very easily. Talking about reflexes, so these people are going to be hyperreflexic. If you're again using that patella DTR for an example, it's going to be a very quick out, very quick back action when you assess that patella DTR. So be on the lookout for that. When you're talking about neurological stuff, these people are going to be talking about their mind's always racing or can't make sense. They're going to be very nervous, very irritable. They can also have memory problems. In terms of weight, as you can see, it's the converse. You're going to have weight loss. Again, 5 to 10 pounds. Another thing that you're going to want to look at in these patients is muscle strength. You're going to see some proximal muscle weakness in these patients. Also, one thing that's not on here, cardiovascular issue. These patients, again, think of them, again, hyperthyroid. They're very revved up, right? Can't make sense. Mind's racing, excessive energy release. We've talked about that. They're nervous. They're irritable. They're going to be tachycardic. A lot of times you can see these patients have atrial fibrillation. In fact, one of the leading causes of undiagnosed or new onset AFib that has just been diagnosed is it can be traced to, in about half the cases, a undiagnosed and untreated hyperthyroidism. So tachycardia and or atrial fibrillation will be very common finding in these patients. In fact, these are patients that we give beta blockers to as a result of some of those cardiovascular issues. We'll talk more about that in just a minute. Let's talk about some GI issues. These people are going to be having hyperdefecation, so frequent loose stools, diarrhea, very low volume. From a menstrual standpoint, it's going to be the absolute reverse of hypothyroidism. And then in terms of cold or heat intolerance, these are people who are going to be very intolerant of heat. So that's what you're looking at most commonly in hyperthyroidism. So some of the common etiology, the most common etiology in hyperthyroidism is going to be Graves' disease. So that's typically a 8-to-1 female to male ratio. It's the most common form of what we call thyroid toxosis, or it's a fancy word for hyperthyroidism. Usually going to see that in age groups between 20 and 40. And again, you're looking at underlying autoimmune disorders. And again, you're also going to have all the symptoms that we talked about before. So these patients, we typically wind up having to put on, and we treat them with anti-thyroid preparations. Most common is methimazole. Or lots of times we'll give PTCU. So you use one or the other. Typically you don't use both drugs due to the fact that it can kill the liver. So basically you're trying to kill the thyroid, right? We have a very overactive thyroid. We're trying to kill the thyroid or achieve what we call a euthyroid status. And then once that's done, usually it's radioactive iodine for thyroid ablation is the next step in therapy. You're not doing that. You're sending them off to someone to do that, by the way. But then they may come back to you once that's been done, and you're going to have to give them levothyroxine or Synthroid. Reason being is because now we've made them hypothyroid, right? So it's going to necessitate the use of a levothyroxine. Again, these patients you're going to send off to have that stuff down, and then they'll come back to you. So kind of keep that in mind. And again, talked about postpartum issues before and some risk factors. And again, most commonly, you can see a transient thyroiditis in the postpartum setting. So just be on the lookout in that subspecialty, that special population of those patients. So we've pretty much kind of covered that. Let's see what's next here. We'll talk about treatment. Again, a little note up there, anterior pituitary excretes TSH. So keep that in mind, where that comes from. So here's some test results, and hey, what are we going to do? So over on the left, there's an example of some labs that you might see. An undiagnosed or untreated hypothyroidism. So we've got a really sky-high TSH here of 84. By the way, it's not the highest that I've seen at all. I've seen numbers where there's been in the hundreds, in the 284 range. Patients actually kind of appear drunk. They have this stupor about them. It's really interesting. They look like they've just been kicking back 12 packs of their favorite alcoholic beverage of choice all day long. But anyway, so TSH, as you can see, is sky high. We're going to want to do what? We're going to want to check this gives you a free T4 level. So you can see that that is down low. It is in the gutter compared to where the normal range of findings should be. So we're going to start these people on Synthroid, or levothyroxine is the generic, right? And it's nice and cheap. It's on the $4 list at Walmart. Terrific. People like that because it's cheap. So the standard dosing here for adults is 1.6 micrograms per kilogram per day in adults. And then you have, for your special populations, elderly, it's going to be lower dose. It's going to be 1 mic per kg per day. And in children, it's going to be 4. Most of your kids, don't try to handle that yourself. Send those off to endocrinology, please. Know your limitations. Anyway, and in pregnancy, there's typically going to be a 50% increase during pregnancy, so you need to make dose adjustments. But anyway, you're then going to come back in about 8 weeks. Literature will say you could do it as soon as 6 weeks. Typically, it's about 8 weeks. So 6 to 8 weeks is your time frame where you recheck your TSH and see if you have them at a therapeutic level. If you do it sooner, it hasn't had enough time to really have a full effect, and you're going to be chasing your tail basically. So you'll recheck in 6 to 8 weeks and see if you have them where you want them to be, and then you're going to see that once you get them to normal limits, in terms of checking, we'll talk about how often once you get them dialed in when you need to check them at that point. But you're going to be adjusting, you're going to be checking 6 to 8 weeks while you're making adjustments. If you recheck after that period of time, they still aren't dialed in, that TSH is still too high, you're going to make a dose adjustment. So keep in mind that anytime you are actively adjusting a patient's thyroid medication, you need to be rechecking your levels every 6 to 8 weeks. And this doesn't matter in terms of whether you're giving your traditional Synthroid or levothyroxine, or we're talking about these desiccated thyroid preparations. You'll have patients that come in on this. They'll be on Armor Thyroid or Nature Thyroid or some sort of over-the-counter. Talks about, these are typically measured in grains. It talks about what that breaks out to in terms of making that transfer into your levothyroxine dose. And basically there are absolutely no controlled trials or studies that support the preferred use of desiccated thyroid hormone over your traditional levothyroxine in the treatment of hypothyroidism. Some people do it just because maybe they have certain ethnic or religious beliefs, or that it's a diet thing. Who knows? But if they're saying that they read this study, which study I use loosely, that means they got into a chat group online somewhere, and now they believe that they're an expert and they graduated from Harvard Med endocrinology school. They're just basically blowing smoke at you because there is no data that supports that desiccated preparations are superior. So, and also one thing you need to know is that the desiccated preparations are either going to be bovine or porcine in nature, meaning either derived from pig or cow, right? Bovine cow, porcine pig. So, anyway, that's kind of what you're doing with untreated hypothyroidism. So let's do an example of untreated hyperthyroidism. So this is someone, you get a TSH that's pretty much almost non-existent, and then opposite free T4 is going to be sky high. Oh, by the way, before I leave this on hypothyroidism, your goal where these patients typically want to get to, where they're going to run the best at and feel the best at, is if you get their TSH down to about a 1.2 for hypothyroid. All right, so hyperthyroidism, almost non-existent TSH, very high free T4. Again, remember the clinical presentation that we talked about. So in the setting of this, we're going to give, like I said, one of the anti-thyroid medications that I already talked about, methimazole or PTU. Again, there's hepatic issues. You want to measure liver functions. When given these, don't ever give both drugs at the same time. You'll kill somebody's liver. And again, these are people that we're typically giving beta blockers to. Most commonly, you're going to see propranolol. Not all. These are both old school beta blockers, by the way. This helps to counteract tachycardia. Also, these patients they'll be complaining of tremors and having issues with that, and that helps to counteract that. Again, I've already kind of talked about the treatment with this. It's going to be, you want to kill the thyroid, get them to a euthyroid state, end result being thyroid ablation. Then you're going to make them hypothyroid, and now you're having to give them levothyroxine. Do read this. It's kind of blackened out a little bit. It was highlighted, but do note that levothyroxine should be taken with water on an empty stomach at the same time every day, typically in the morning, separated 1 hour from meals or any other medications, and should not be taken within 2 hours of calcium, iron, aluminum, magnesium. I'll talk more about that in just a minute. So then we have what we call subclinical hypothyroidism. So elevated TSH, normal T4. But these are the patients that we're thinking, oh, there's something going on from an autoimmune standpoint. You get your autoimmune, you get your TPO antibodies. Those are typically going to be elevated, and you'll see what we call subclinical hypothyroidism. So typically, the American Academy of Endocrinology, College of Endocrinology, their guidelines recommend treatment of patients with subclinical hypothyroidism if they have a TSH greater than 5, if they have a goiter, or if thyroid antibodies are present. They usually are going to be, typically going to treat these patients, or if they have the presence of symptoms that are compatible with hypothyroidism. And you're going to treat them just like you would any other hypothyroid patient. So you will see some literature that talks about a watch and wait approach with periodic testing of TSH and free T4 every 6 months. But again, guidelines from the American Association of Clinical Endocrinologists is going to recommend that you go ahead and treat these patients if they got a TSH that's greater than 5, or if the patient has a goiter, or if those TPO antibodies are positive. And usually that's going to be the case. I can't think of any cases of subclinical hypothyroidism that I've had where I've done a watch and wait approach. They've all had one or several of these symptoms that have required going ahead and treating. So keep that in mind. So say we get our patient to goal. We get them dialed in. The TSH is staying stable over time. So once you've gotten an adequate replacement dose and you've got them dialed in terms of your TSH, in terms of how often do you check their TSH, typically you do it after 6 months. And then again at 12-month intervals. Now, of course, this can be done more frequently if the situation dictates. So if they become symptomatic, then of course definitely might want to check that level. So that's kind of how you're going to do that. So another thing to keep in mind is that if you, in the process of dialing them in, sorry, I'm kind of skipping around a little bit. If you're trying to get them dialed in, you recheck that TSH, and they aren't where they need to be. So the TSH, we're dealing with hypothyroid So say the TSH is greater than 4. Then you're going to increase your levothyroxine dose by 12.5 to 25 micrograms, recheck 6 to 8 weeks, right? Alternatively, if TSH is less than 0.5, you will decrease your levothyroxine dose by 12.5 to 25 micrograms and recheck in 6 to 8 weeks. And then again, once you've gotten them dialed in, measure the TSH at 6 months, then annually or when symptomatic. So, so that's kind of what you're doing with that. And then again, keep in mind, patients that are taking levothyroxine, it needs to be taken at the same time every day on an empty stomach with water only. Ideally, first thing when they get up in the morning, they need to hold off eating breakfast for ideally about an hour. And again, they need to separate from any other medications as well. Sometimes this can be an impractical thing with today's hurry up and go lifestyle. So another thing that you could do is have them take their medicine 4 hours after eating, with a 1 hour wait after dosing. So that's another alternative. But try to get them to do it first thing in the morning, right when they get up, throw it down the back of their throat. I'm even happy if I can get 30 minutes out of my patients before they eat or take their other medications. But for guideline purposes and testing purposes, an hour is what you are shooting for. So the final thing to kind of talk about then would be evaluation of a thyroid nodule. First, let me tell you that the majority of thyroid nodules are very discrete, and by that I mean they're small, less than 1 centimeter in diameter. A lot of times you can't feel it. Going back to your assessment class, we went through how to palpate thyroid. Right, we have 2 lobes, a left and right lobe. And you can have nodules on either lobe. But very rarely are you able to actually palpate a nodule. Is it large enough to palpate? Ultrasound will usually pick these things up. And that's another thing that once you have someone who's been diagnosed with thyroid disease, you want to put some jelly on that neck and get a thyroid ultrasound. A lot of times that will reveal a very common finding on report on thyroid ultrasound is multiple discrete nodules, and it will give you measurements. They're typically usually around 1 centimeter or less, and you're really going to have a hard time feeling that. You will occasionally get a very large fixed thyroid nodule that you can palpate, and that can kind of be a challenge. One thing that you may see associated with that would be localized pain, maybe some dysphonia, maybe some hemoptysis and coughing up blood. You may have some regional lymphadenopathy. That can be tricky because you're trying to determine, okay, is this a lymph node or is this a nodule? Again, thyroid nodule is going to be very hard and fixed mass, different from lymph node, right? We know that, again, going back to assessment testing. So if you find this, by the way, on somebody who does not have underlying thyroid disease, first thing you want to do is what? Draw a TSH, right? You want to check that out. So you'll read stuff about thyroid uptake scans and so on and so forth, and that's all well and good. But in terms of thyroid nodules, the most definitive way at arriving at a diagnosis, and also the most cost-effective, is you send these people off for a fine needle aspiration biopsy. Again, the truth is in the tissue, right? There's a saying in oncology about that. So you want to send it off for an FNA, fine needle aspiration biopsy. And again, that's what's going to give you a definitive diagnosis. It's going to do more so than an ultrasound or a thyroid uptake scan in terms of whether or not that lesion is, or that nodule is malignant or it is benign. And they're pretty accurate too in terms of their sensitivities. So there you go. That's thyroid in a nutshell. almost under 30 minutes. I went just a little bit over. So, hope you found this helpful. As always, any questions, please email me with ND2L. You can call, you can text me. And again, a lot of this material you will see again very soon and shortly. And again, this is just kind of condensing things down, trying to put it into just a few pages and a little added lecture, some clinical pearls, make it easy to understand. Please, if you refer to your readings to help kind of beef this up or look at up-to-date or other resources. But there you go. Hope that helps. And as always, any questions, let me know.